All right, welcome back to another episode of Fifth Generation Leadership. Today, I have an awesome guest, Dr. Chris Clagett, 34-year veteran, uh, Navy captain, so '06 preventive medicine physician, who actually started out as a physical therapist. So we have that common ground, and looking forward to talking with him about uh, basically the risk benefit of applying the COVID military vaccine mandate. And uh, I became familiar with Chris because we're both signatories of the Declaration for military accountability that was penned by Commander Rob Green. And so, became familiar with him, looked into his background. I was like, oh, wow, this guy is, exactly who I would have expected to stand up, like all the other people that are preventive medicine physicians and epidemiologists, and just no one did it on active duty. And so really looking forward to having a candid discussion and looking at some of the evidence and some of the clinical reasoning that made me feel like I was taking crazy pills as a physical therapist, saying, hey, the clinical reasoning for mandating this just seems absolutely insane. But, hey, this is outside my scope of practice. So like, am I really the person to be the one to say something about this? So just wanted to get that perspective from a real subject matter expert. I mean, there's no greater expert on looking at whether or not applying a treatment to the entire population, an entire population the military is indicated, than a preventative medicine physician. I mean, there's just not, there's other experts that you could say have like equal part to weigh in, but I don't see anybody else as more of an expert, more of an appropriate authority, especially somebody as senior as Chris. So all that said, welcome, Chris, and feel free to take a couple minutes to give background on yourself, anything that I might have missed.
Sure. Well, without boring your guests with all the details of assignments here and there and the other, the core of my experience that's really pertinent here is my work in Navy preventive medicine. I spent 6 years as the director of preventive medicine, and then named Navy and Marine Corps Public Health Center. I think now they're renamed. It's Navy and Marine Corps Force Health Protection Command, a little bit analogous to Army Public Health Command. The in the naming convention, functionally they're exactly analogous, and I can't remember what the Air Force counterpart is called anymore. Uh, so I spent 6 years there as the director of preventive medicine, and that tour was bracketed by 6 other years divided between two of the Navy's regional preventive medicine units. The Navy has four of them worldwide. I spent 3 years at Preventive Medicine Unit 7 in Sigonella, Italy, and the other three at Preventive Medicine Unit 2 in Norfolk, Virginia. And preventive medicine is in the military is a fascinating specialty, and so that is really what qualifies me to talk about this subject. When you mentioned this conversation, Grant, that you were interested in doing this, uh, looking at risk benefit ratio of the what are labeled as vaccines for COVID-19. Whenever you have a new pathogen that rears its head and is infecting large numbers of the population, it's brand new. The first thing you do is develop a case definition, the clinical presentation of the infecting agent, and it's all very crude at the beginning. And your first measure that you go for is what's called the case fatality rate. So of the cases that you see meeting the clinical case definition, who dies? How many? But that's not where you want to stay, because except for pathogens like rabies, everything has an asymptomatic rate. For rabies, it's effectively zero. Nobody is asymptomatic with rabies. But everything else has an asymptomatic rate. And so in order to, you want to progress from the case fatality rate to the infection fatality rate to get a true measure of the virulence of this new pathogen that you're interested in. So in order to calculate that infection fatality rate, you've got to wrap your arms around the universe of infections in the population, which means finding out who the asymptomatics are and who also maybe have had symptoms that didn't feel ill enough to go seek medical care. Those people exist also. And when you add those groups into the numerator of deaths, which you're really expanding only the denominator, you get your true infection fatality rate. The thing that caused many of us to begin smelling a fish in 2020 was that the CDC never moved beyond the case fatality rate, and eventually in the media, all we ever got were counts of cases, which in many cases, or in a large portion of them, were simply laboratory positive cases, where the person who tested positive, they had no idea that they were ill. They got tested for some reason. Maybe they were exposed to an unknown case, but they themselves were fine. But they got tested, and positive tests, all contributed to the case count. But the case count is not the important thing epidemiologically. We want to know the infections, and then a hospitalization rate, and then a mortality rate as a percentage of case infections. They never did that. All the way into 2021, and even really to the present, they don't. Although these data now exist, and they were based on seroprevalence data, and that's how we get that universe of infections. Whereas you simply go do some population-based sampling and take blood from people, and then simultaneously question them about any symptoms that they might have had that would have been referable to the new pathogen. And you find out, so who has antibodies that never had any symptoms, and who had antibodies that had, I did have a cough for a few days and maybe a little mild fever or a headache around, September. But they never saw medical care. I mean, these studies started to be completed even within 2020. I think I have in my files at least 3 papers dating from 2020 that were based on seroprevalence data. And so these researchers were trying to get their arms around the true infection fatality rate, which was way less than the American public was being led to believe. Because there were surveys done in 2020 and 2021, about public perception of how virulent this, I call it the Frankenvirus, because it's a chimera, an artificial man-made chimera between a bat coronavirus and HIV. Pieces of HIV were spliced in. So they started doing the seroprevalence data, looking for antibodies in a population. There were a couple of studies done by Stanford. One study was done by Stanford University, and they estimated a 50% asymptomatic rate. The CDC itself estimated a 35% asymptomatic rate, but you never really heard that in the news. The American public thought that 50% of all infections required hospitalization, when the true number is 1% or less. And so, so many of us, we smelled a fish in 2020 going into 2021. Actually, even by the summer of 2020, there were indications that the CDC wasn't really investigating this properly. They were still stuck on cases and counting cases. So, without knowing that true denominator, that's your first step in figuring out the risk benefit ratio of some later intervention, be it a drug therapy, a vaccine, or anything else that you want to do to try to mitigate the problem. If you don't have your arms correctly around the problem, and you don't know the scope of the problem, you can't intelligently make recommendations about mitigating actions. So, yeah, they really they flubbed that one, and well, that's actually generous because that implies accidental. It really did look kind of deliberate.
Well, I
So
think what you said about you have to wrap your arms around it in order to be even able to calculate risk benefit. So they were saying a lot of times they would say the phrase, out of an abundance of caution, we're going to do X intervention, right?
right,
And but that assumes that interventions are without cost. Everything that
yes,
you do has a cost. And you mentioned Stanford in some of those seroprevalence studies. I think one of those was authored by Jay Bhattacharya, right? And so that was one of the reasons that he was coming out, with the Great Barrington Declaration, talking about trying to isolate, potentially more vulnerable populations. But even at that time, they didn't know exactly how vulnerable populations were because they didn't have that infection fatality rate. And it's almost, like you have experience over the course of your career seeing things come and go and how quickly the situation developed. And correct me if I'm wrong, but the way that it was developed with this was not commensurate with what was done, for example, for swine flu and other pandemics in the past.
right. So, speaking of pandemics in the past, so the archetype for that is 1918, and the accepted overall mortality rate in 1918 was about 2%. But what is not known, or widely known today, is that we are comparing apples and oranges when we think about pandemics now and 1918. That was a pre-antibiotic era, and a lot of the young adults, the median age of a fatal case in 1918 was 38. These are young adults. What was happening to them is they were developing bacterial follow-on pneumonias. So it's what we call a secondary bacterial pneumonia after the primary viral pneumonia. And there were no antibiotics to give anyone. And the other thing that has come out was that there was a brand new pharmaceutical that was just being produced. It was devised by Bayer AG, a German pharmaceutical company, called aspirin. Well, the accepted modern maximum 24-hour dose of aspirin is about 4 grams. So our standard pill is 325 grams. So generally you can take 3 of those 4 times a day, and you're taking just a little under 4 grams. They were using clinical protocols that were using anywhere between 8 grams and 30 grams a day. Now, anyone who swallows and absorbs 30 grams of aspirin is going to die. And there isn't anything anybody can do about it. So a good portion, an unknown portion of the mortality in 1918 was what we call iatrogenic, The doctor did it. And in the but we're a whole century later. The biggest lie that was told to the world in 2020 and 2021 is that viral pandemics, to use the inflammatory word, are dangerous to modern pharmacologically sophisticated societies. They are not. And so that was the first big lie, is that this is a dangerous pathogen. And so this staying stuck on the case count, that basically furthered that lie in order to give people a distorted perception of the magnitude of the danger, because the virus in 2020, the average fatal case was 80 years old. These are people that in the United States would have exceeded the life expectancy from birth by a few years, a couple of years for women and about 3 or 4 years for men. So fatal cases on average were just waiting for the next pneumonia to come along, influenza pneumonia, or strep pneumonia. That common. 50% of us are colonized with it, but in some people, usually the elderly, the organism gets out of hand and causes a bacterial infection. We don't know that they weren't infected all their life, or colonized all their lives. Maybe not, but you can't tell. It's a common organism.
So just to comment on that, because I'm seeing parallels to 1918 with what we saw with COVID. First of all, the parallel between aspirin and remdesivir, where that's a toxic medication that just didn't have a great track record and was included in protocols. And then also that comment about these opportunistic bacterial infections, which we now have the ability to treat with antibiotics, where I've seen hospitalists, because I was obviously riveted by this, what was going on, because I had, strong feelings about it. And I saw hospitalists commenting on how, the typical practice of doing a culture for somebody in hospitalized inpatient in order to identify, those secondary and bacterial infections, and what, do a culture and find out what it is in order to match the appropriate antibiotic.
They
For
weren't doing
COVID
those,
patients, they weren't doing it. They're like,
right?
no, just not going to do that. And so then they're not getting antibiotics,
That's right.
so, they're in this, and then on top of that, put on a ventilator, which is going to, with that overpressure, push that infection deeper into the lungs. And, that's why perhaps there was such a low survival rate once people were sick enough that they were put on a vent, and then given remdesivir on top of that. And that's where I think that term iatrogenocide, comes from, is just from that practice. And then them using the fact that a lot of people died that very way to demonstrate how dangerous this pathogen was, when, some of it was exacerbated by the interventions that they were executing in the hospitals.
And for our listeners that really are not familiar with remdesivir, one of the main adverse reactions from it, which is a highly prevalent adverse reaction, is acute kidney failure. So, what do our kidneys do? They get rid of fluid waste. When the kidney fails, it stops doing that, and so the body becomes loaded, fluid loaded. Now, the lung is normally a dry environment. It must be, because alveoli that get water in them cannot exchange gas. So the lung is a dry environment. But if you fluid load the body, then the lung begins to leak from the vascular space through the first into the what's called the interstitium of the lung, the spaces between the cells of the lung between the wall of the capillary and then the wall of the alveoli, and this very small space begins to fill up with water. Carbon dioxide has no problem traversing that space because carbon dioxide is highly soluble in water, but oxygen is not highly soluble in water. So in normal lung function, the oxygen diffuses across the alveolar cell, the cell of the lung that makes the boundary of the alveolus itself, and then one small cell or thin cell thickness of the capillary. So these are we're talking a total distance of single-digit microns. A red cell, for example, is on average 7 microns in diameter, and the thickness of the capillary cell and the alveolus wall combined is much less than that. A third, half, somewhere in there. It's thin. But if you put edema in there, because the body cannot get rid of fluid because you've killed off the kidney with remdesivir, then the first thing that happens is you begin to get that edema. And then if the edema persists, then the edema begins leaking from that interstitial space into the alveolus itself and flooding the alveolus. And now you've got no gas exchange. And when a sufficient portion of the lung floods, then you effectively drown. And that's what causes this pulmonary death. So yes, in 2020 and 2021, a lot of the hospital death was iatrogenic.
So let's move forward into, like setting the stage. We have this situation where we're not getting a good bead on infection fatality rate, which is really the information that we need to know about any treatment and whether or not it's going to be a positive risk benefit. If we're going to get absolute risk reduction from all cause morbidity and mortality from applying any treatment, we really need that infection fatality rate.
Is now a good time to look at a paper that examined this? There were like something on the order of 40 population-based studies conducted by and archived by national health databases in 26 countries. Now this was a later paper, but I mean we now have 2020 hindsight on what these values were and stratified by age.
Yeah, let's look at that. Let's look at that
Okay.
so that we can establish going
Right.
forward.
I'm gonna share my screen. Hold on a sec. Let me get over, make sure I got the right paper up. Age stratified. Here we are. Yes. Okay. Yeah. And this was, who did this? Oh yeah, John Ioannidis. He's the main guy. All right. Let's see. I'm gonna come back, share this page of the paper. Here we are, sharing it now.
Yep,
Okay.
I can see it.
Are you looking at it?
Indeed.
Okay. So here we are. Can you see my cursor?
I can.
All right, I'm highlighting this section. All right, actually, let's do this. The infection fatality rate was 0.0003% for those age 0 to 19, infants through 19 years of age. Okay, so this is on a numbers basis, this is 3 per million. That's the infection fatality rate pooled across 40 studies done in 26 different countries. 3 per million.
And that is still including all those caveats that we discussed. So
Yes.
including the fact that people were not being given antibiotics when it might have been indicated, including when people were given remdesivir when that might not have been indicated, put on ventilators when that might not have been indicated, and
Right.
not using potentially appropriate repurposed drugs that there's a lot of controversy over, but hydroxychloroquine, ivermectin,
Right.
using steroids like prednisone to knock down inflammation when there is problems with gas exchange in the lungs, like when there's pulmonary inflammation. So
Right.
all those sorts of things that uh, might contribute to an increased infection fatality rate, that is factored in to that already very low number. Or
Right.
is that accurate?
That's approximately accurate, but the very young that we're looking at right here, they almost don't acquire the virus. So these are not people that are going to be hospitalized, and basically anybody in that age group that's hospitalized has probably got some sort of major pre-existing morbidity
So any
that make
positive test is kind of an incidental finding.
yes,
Um,
that's making them vulnerable to that virus. Let's move on to the next um, age group. So we're looking at 0.003%. So it goes up by an order of magnitude in the next decade. So this is 3 per 100,000 mortality. Now, this is our military population, okay? 20 to 29, 3 per 100,000. That at that rate, across all of DOD, the active component, which I think is somewhere around 1 million. So that would be 30 people.
and that is what we saw in that population
Yeah,
for COVID deaths prior to the rollout of the vaccine.
right. And then for 30 to 39 year olds, 0.011%. So that's let's see, that's 11 per 100,000. Yeah, 11 per 100,000. And then 40 to 49 year olds, that would be 35 per 100,000. And then now we're starting to, people are starting to accumulate wear and tear and a little bit of chronic disease. So for 50 to 59 year olds, this would be just over 1 per 1,000. So 1.2 per 1,000, 12, almost 13 people per 10,000. Exactly here as they calculated, it would be 129 per 100,000. And then they stopped their estimate for the 60 to 69 year olds, and that's 501 per 100,000, or approximately 1 every 200 infections in 60 to 69 year olds will succumb. And
And so
they did
that looking at this, we have the 3 in 1,000 for that age brackets. That's the bulk of the military population. So, the clear majority, you might
yeah,
have a better sense, but I'd estimate probably around 75% or more of the active force is in that 20 to 29 year bracket because of
seven,
the
yeah,
overwhelming overrepresentation of 17 to 18 year olds coming in to do a 3 to 4 year tour straight out of high school,
yeah,
um, and then getting out, and that turnover making that be a huge portion of the population. But
right,
also noted in that population is, by definition, we're not getting into comorbidities yet, but one of the biggest comorbidities, and I don't know if this study looked at that, but we both know, is obesity. And by definition, um, or by regulation, I should say, there are limits to your allowable body fat percentage in the military, and those limits are underneath that level at which you have increased risk from fatality, from COVID infection, from obesity.
Yep.
So, that's another huge factor that's going to take that 3 in 100,000 and push it down significantly. Now, how significantly, I don't know, but certainly that active military population in that age range in the military has a much lower rate of obesity than the general population.
And for anybody that's not familiar, I saw a paper a couple of years ago about what was the connection between obesity and worse outcomes with the Frankenvirus, and it seems to preferentially replicate in adipocytes. It Adipocytes express the ACE2 receptor, I guess, fairly abundantly, and the virus goes there. And so, if you have a lot of adipocytes, uh, the virus has fertile ground, very rich, target-rich environment in order to hijack cells and then replicate itself. But
Yeah.
I'm going to stop sharing that uh, paper. I don't think we need that anymore. But yeah, so let's see, where were we? So we're getting into uh, pharmacologic measures, as in the government is saying there are none, and we know that's not true. Uh, do you want to get into that, or stay with the
Yeah.
vaccines?
Yeah.
Okay,
Let's try and I know that topic can go really deep. So by all means touch on it because I think we see eye to eye and I think it needs to be mentioned,
sure.
but we don't need to cover the literature because I know there's a lot of bad faith actors because of the incentives associated with that, where they
Yes.
had to ensure in order for a emergency use authorized product to be authorized, there couldn't have been any alternative treatments. And so, um, just that perverse incentive can make it so that the thing that I pull out and that I think is very persuasive evidence was the use of ivermectin as prophylaxis
Yeah.
in Argentina. So when I found out about that study, people get really wrapped around the axle about randomized controlled trials and they think they're all created equally. But I mean, that trial where they randomized healthcare workers into two groups and gave one ivermectin as prophylaxis and the other group nothing, and the group that got ivermectin as a prophylaxis, and we're talking, I think, 4,000 healthcare workers, two groups of about 2,000 each. The group of healthcare workers that got the ivermectin prophylaxis, no infections, no COVID infections. And
There
the
have
other
been a
group
number of
had, I,
studies.
I think, over 50%, which I thought was a absolutely insane result to ignore. Because if you're going to say that that's not significant, then that would have had to have been outright fraud to produce a result like that. And while that's certainly conceivable, I just don't think that anybody had an incentive to do that in Argentina at that time.
Right. The There have been a number of studies, many actually now done overseas that you can't do in the United States, that have looked at the efficacy of ivermectin both as a prophylaxis and as a treatment for acute outpatient and uh, acute infection in an outpatient setting with excellent results. But rather than go through the literature, I think what we can do is just remind people of events in the news that they'll remember, and when we can point out basic historical facts. So in, I don't know, what was it, March maybe of 2020, President Trump got on national television and said, yeah, we got this novel flu virus coming out of China, but not to worry, we got a good treatment. It's called hydroxychloroquine. And instantly, hydroxychloroquine, which I like to shorten to HCQ because hydroxychloroquine is a mouthful, it became Drano, fishbowl cleaner. So fishbowl cleaner actually is chloroquine phosphate, completely different molecule and quite toxic. But hydroxychloroquine was approved by FDA in 1955. And in the now almost 70 years that have elapsed since then, HCQ has been used by over 1 billion people. I mean, we may be approaching 2 billion people that have used this medication. It's got one of the safest adverse reaction profiles of any pharmaceutical ever manufactured. I mean, in a public health perspective, we used it for malaria. And when we lost its use because of its abuse as an anti-malarial by the mining industry in the Thai-Burmese border, we mourned the loss of HCQ. And in the 1970s and into the very early 1980s, in public health perspective, we were watching people die of chloroquine-resistant Plasmodium falciparum, one of the worst of the 4 species of malaria that will infect humans. And then the Army rode to the rescue and developed mefloquine, for which the world is indebted, because mefloquine saved lives. And then the mining industry abused that one too, and we lost mefloquine. And Fansidar, and eventually the artemisinins, and every other antimalarial every successful antimalarial has come along. We've lost because of that mining industry. All antimalarial resistance begins on the Thai-Burmese border. Anyway, so we mourned the loss of HCQ as an antimalarial, but in the United States today, the main people using HCQ are people with lupus and rheumatoid arthritis. These are autoimmune conditions, and what HCQ does is it basically modulates the immune response, which actually is what you want in the setting of a viral pneumonia, because in a viral pneumonia, the damage to the lung is not done by the virus so much as the immune response to the virus. And HCQ is very helpful because it just kind of dials that response down. And I think it's got other effects that are not necessarily well understood, at least not by me. But it became Drano. And CDC and FDA would have both known that HCQ is not Drano. It's not toxic. It's not like swallowing Drano. It's not like swallowing fishbowl cleaner. But they both sat back while leftist memesters vilified one of the best pharmaceuticals ever made as Drano and fishbowl cleaner. And then, as you mentioned, there's ivermectin. Ivermectin kind of its repurposed utility was discovered later in 2020, and ivermectin became the horse paste. Ivermectin was approved by FDA for human use in, I think, 1987. We gave it to humans exclusively for intestinal parasites. Gave it to them exclusively to humans for years before anybody thought to give it to livestock or horses. Ivermectin, like HCQ, has an extremely benign adverse reaction profile. The FDA-approved dose is 0.2 milligrams per kilogram body weight. I've personally seen papers where volunteer subjects were given twice that and 3 times that. And a good friend of mine, who's also a retired Navy PrevMed physician, told me about a paper that he found where volunteer subjects were being treated with 6 times the approved FDA dose. And then when you finally do manage to take a little too much ivermectin, the symptoms are primarily gastrointestinal, nausea, vomiting, but it's not going to kill you. You take too much Tylenol, it's going to destroy your liver, and then you're going to die.
Especially by 6-fold. If you take 20 or 30 grams of, say, aspirin or Tylenol, you're
aspirin
toast.
will kill you too. Oh, yeah.
But just to comment on, some of the literature for HCQ, one of the things that was done. So you mentioned the crazy dosages, which is kind of a way to sabotage a treatment and a trial. But another way is, from my understanding, based on, kind of reviewing some of the literature and the number of studies, and there were a large number of studies, is the studies that included HCQ early, so prior to hospitalization, It was shown to be pretty effective. But
Pretty
then
effective.
later on, once you're already hospitalized, it's
Too
just not
late.
able to do that. And based on the mechanism of action that you outlined, where you're really trying to prevent damage from your own immune system, that makes sense because once the damage is done, that
You can't undo
medication
it,
is going to be helpful.
right?
And these subtle things like considering the mechanism when you're designing a study is something that you would think would be obvious, but that's if your intentions were to try and actually learn something and figure out something that works, as opposed to ensuring that you could demonstrate plausibly to the American public and to the regulatory agencies that, hey, we don't have a viable alternative medication
Right,
to this experimental gene therapy that we're developing.
right. So one of the legal requirement for an emergency use authorization is that there be no alternative. So in order to sell the gene agents to the American public, uh, the access to alternative therapies had to be crushed. And the way they did it was to have the state medical boards uh, suspend the license of any doctor that prescribed it. And I think pharmacists also had action taken against their licenses if they dispensed it. For physicians board certified in some medical specialty, uh, the, uh, the the regulating board is not state-based, but it's national. So, if you're in some, say you're an internist, and you think one of these uh, medications would be useful to your patient, you prescribe it, and the pharmacist turns you in, you could lose your certificate, your certification as a specialist in internal medicine. This is a very real thing, and that's, I think, one of the things that we need to reel in is the power of state medical boards. We've never had this kind of abuse before, so there was never any reason to put any kind of check on their power, because they, as far as we really know, they've always acted in the best interests of the public in the past. But they're clearly guilty of not acting in the public's best interest now, and that needs to be fixed.
Yeah, that's so. I mean, I would say that probably it has been an issue up until this point, but never as obvious as in this particular instance. So I'm kind of a free market guy by background. So I've always been skeptical of regulatory agencies and wary of the prevalence of regulatory capture. If you look into the history of the American Medical Association and how it started and allopathy kind of going to war with other um, approaches. Not to say that allopathy isn't totally necessary and appropriate in a lot of circumstances, but kind of the interpretation of allopathic medicine as the only type of medicine
Mhm.
is something that is related to that issue, where it's pushed a lot of folks out of the ability to prescribe medications. So if you give a monopoly on the ability to prescribe medications to a credentialed body, I don't think in the past it's been used so much to dictate how physicians practice once they are licensed. I think the bigger concern previously was that it was used to uh, just monopolize the ability to provide medication to this credentialed class and then controlling access to medical schools where you had to meet these certain criteria, and that was kind of the gate where they created a bit of a cartel. But that's a whole nother
You're
topic.
absolutely right. So you're alluding to a lot of history about the AMA and how it got started. And I've never been an AMA member, um, but that's exactly right. Back in the 1800s, they got started, and it took a while to literally probably 20 years or more of lobbying, but they eventually got their grip on state licensure and promptly put dozens of osteopathic schools of medicine out of business. And yeah, people may not know that history, but that's the way it worked. It was all about essentially a trade guild that was trying to control the market.
Yeah, and it's like you said, I don't think, and you would know better than me being a physician practicing over the course of the past 30 years or whenever you switch from PT. But it used to be that there was this notion, especially in America, that that uh, doctor-patient relationship was sacred. And it's like if you're that credentialed provider and you have that education, then the onus is upon you to take care of that
Yes.
patient. And I
Right.
think going back to accountability and that declaration that we assigned and how important accountability is, who's more accountable to a patient than the provider that's got to look them in the face? And then you have these bureaucrats sitting on these licensure boards that don't have to face the family member of a patient that you failed to adequately treat, and yet they're making these decisions. So I think, um, and I think it's very popular, that idea with most people, most Americans, the idea that a physician should be able to unilaterally determine what treatment's appropriate. Otherwise, what function do they have in society? Like, do we really
Right.
need these boards that are able to, not be the one sitting in front of the patient and then using literature that has the pressure of regulatory capture upon it? And not only that, but we have the replication crisis in all of science, where more than 50% of landmark papers are not able to be replicated, which means they're junk. So we're
Right.
looking at, hey, they're trying to make clinical practice guidelines based on this literature. And we know for a fact that more than half of the literature is junk. It can't be replicated, which means that it was not a legitimate finding. There's not a statistically significant difference. It's not safe when you might have calculated in that individual study that it was safe.
Mhm.
And now we have boards aggregating these studies and then making determinations based on. It's a very dangerous
Yeah.
precedent, I think. And this is a perfect example of how crazy it could get, where you have these very safe medications. You could argue about efficacy and what the appropriate dose is and the window, but what's difficult to argue is that they are not safe, especially when you compare it to the track record of a brand new novel gene therapy, right? So I guess that's a good opportunity to pivot into
Sure.
the vaccines, or maybe to be more accurate, gene therapies when they came onto the market, and the degree of certainty that medical providers were indicating that it was going to be safe and effective, and that safe and effective mantra, which to me, um, I'm somebody that, personally, I'm willing to take some risk for my own health to try different things, sports supplements,
Mhm.
etc. And, the government's not necessarily excited to let you do that. There's regulations and stuff, and especially for medications, like you can't just go take a medication. You need a physician to prescribe it to you. And that's the idea is, hey, like that's for your safety. And then now we have these new treatments. And then especially like what I call a slam dunk argument for just highlighting the absurdity of it is the fact that it was not tested in any way, shape, or form on pregnant or breastfeeding mothers.
Right.
And yet it was
Historically,
recommended on that population, which, to give you a physical therapy example, you do battlefield acupuncture on the lobe of the ear, right? And there's different segments of the ear that correspond to different body regions for managing pain, right? And one of those regions is the womb. And so battlefield acupuncture is contraindicated for pregnant women,
hmm,
because you stick a acupuncture needle in an area that corresponds to the womb, and that's considered to be too dangerous, so it's contraindicated.
hmm.
And yet it's no problem to use this novel gene therapy. So um yeah, I mean, were there any other points that you wanted to make before we kind of transitioned into talking about
No, I
risk
think now's a good
benefit?
time to move on to the gene agents. And I think the audience would be, why do we call them this? And we call it this because that's what they are. So these nucleotide modified RNA, it's not normal RNA, it's modified RNA, codes for an entire 1,200 plus amino acid functional protein, the spike of the virus. So this is in the virus's normal genome, and its genome is RNA. This lengthy sequence of probably over 3,700 nucleotides, thereabouts, is going to code for this 1,200 plus amino acid protein. So for anybody that is not familiar with this, every three nucleotides codes for one amino acid. That's called a codon. And so this would be a segment in the virus's genome that they lifted entire and created this injectable biologic out of it. And they put it into this lipid nanoparticle mixture. We were told, the world was told, that these lipid nanoparticles would stay at the injection site, but they don't. They go everywhere. And I found a book chapter that was available for sale on Elsevier Science Direct, dated 2012. You can buy this electronic EE book chapter, dated 2012, on how we're going to use lipid nanoparticles to deliver drugs to the brain. So the brain is a very privileged area in the body. It's protected by this thing called the blood-brain barrier. Not many things get through there. Most medications have a hard time getting through the brain. Most viruses and organisms have a real hard time getting in to invade the brain. But the lipid nanoparticle slides right through that and goes straight into the brain and can infect any central nervous system cell in the brain. And they knew this in 2012, that there was enough information to produce an entire book chapter on using lipid nanoparticles in this fashion. And so nearly a decade later, when they said, it stays right there in the arm when we inject it into the deltoid, that was a lie, and they knew it was a lie at the time they said it. It wasn't an oops, somebody didn't know. They knew. So it's a gene, and it goes everywhere. Let's see. You think? Let's see. Oh, now here's another real important thing that distinguishes these gene agents from historical true vaccines. In the historical vaccine, the amount of antigen, the foreign substance to which the immune system is exposed, is very carefully controlled. That is very tightly regulated. Our first exposures, say when we're doing a primary series, might be a little bit of a larger dose, but when we give you a booster later down the road, that's going to be a smaller dose, much smaller dose, because the immune system doesn't need a lot to remind it what that foreign thing looks like in order to give it a goose and rev it back up into action. So there's another feature. Grant, stop me if I start kind of getting, because I'm trying to keep lots of thoughts in my head at the same time and juggle them and put them in a logical order for the listener. So we've got that. It goes everywhere. I think an important thing for people to understand, what makes these different, is how they work. So let's talk about attenuated live virus. We only use 2 vaccines that are attenuated live virus, yellow fever and polio. I remember my first yellow fever immunization. Made me sick as a dog. Fevers, body aches, my arm hurt where I got the shot. I got over it. We in the DoD, we boost yellow fever decennially every 10 years. Second one and third and fourth, I was in a long time, so I got several. Nothing, absolutely nothing. So after the first one, I had circulating antibody, and then 10 years later, when they gave me that booster, a more attenuated live virus, I had circulating antibody. Most of that virus never made it into my cells. Live virus gives a stronger immune reaction, but it comes at a little bit of a cost because you have to have a real live functional virus that invades a host cell. That's, you're the host, you the vaccinee, and it hijacks cellular machinery to produce virus. And that cell that produces virus gets destroyed by immune attack. So you sacrifice a few cells to elicit a more vigorous immune response. Okay, so in the boosters of yellow fever, most of that virus never made it to a cell. It was neutralized by circulating antibody waiting for it. Now, lipid nanoparticle. This is a material that is completely alien to the immune system. Our immune system is incapable of recognizing it. It's like a stealth bomber flying under the radar. We don't even see it. So 100% of that lipid nanoparticle dose is going to find some cell somewhere to invade, to slide into. It just slips right through the cellular membrane and releases its payload in the cell's cytoplasm. The RNA, the modified RNA, goes through ribosomes, produces the spike protein, which is eventually extruded from the cell, and then the immune system sees that. So these cells that are producing foreign proteins have now summoned down upon themselves the artillery of the immune system. They are destroyed because the immune system sees them not as just making a foreign protein, but it sees them as virus infected. Now you get to the next shot or the booster after that. Yeah, you got circulating antibody, but that antibody does not interact with lipid nanoparticle. So the entire payload of lipid nanoparticle on the second and subsequent injections finds cells to slide into and commandeer and force the production of more spike protein. Now, I mentioned at the very beginning of this that historical vaccines, we control the quantity of antigen that the immune system sees. In these gene agents, what the pharmaceutical company is trying to control is the amount of genetic material that's delivered. They don't actually succeed in that very well, but that's the objective. The amount of spike protein that is produced in response to those gene injections is completely unknown, and it's large. So the CDC and FDA and Pfizer and Moderna are telling you that because you make all these antibodies, in fact, you make more antibodies after the gene injections than somebody who had natural infection makes. So you're more protected. No, you're not. So what happens with these gene injections is that you make so much spike that it functionally becomes like an allergy shot. And in a minute, we're going to go to the next paper that I want to share with the audience. It functions like an allergy shot. So you've probably all heard of children who had peanut allergies, and what's happening there is that mom never fed the child PBJs as a young kid. And then the kid encounters peanut protein later. And the immune system says, wow, we didn't make this here. That doesn't belong here. Sound the alarm and trigger maybe an anaphylactic reaction. Not what you want. But the young child whose mother gives him PBJs a couple times a week, because peanut butter is great food, he actually absorbs small peptide sequences from the peanut protein, and the immune system recognizes that and says, well, we didn't make that here. And it seems to be coming around pretty regularly, and there's a lot of it. So call off the artillery. Now, we make many different types of antibodies, but one of the important ones for fighting bacteria and viruses and cancer cells is immunoglobulin class G. We call it IgG. IgG is very conveniently is divided into 4 subclasses, conveniently numbered 1 through 4. Okay, IgG1 goes after viruses and cancer cells. IgG2 goes after kind of irritants, environmental irritants like bee venoms and a few other things that you want to clean up, but it's not an emergency. IgG3 is your main antiviral antibody. And then we have IgG4. And all 4 of these subtypes are coded for in the plasma cell that produces antibodies. And the plasma cell actually has this unique trick. It can change classes by what it does with this gene is if it starts off producing 1, but maybe it wants to hit IgG3 because we got a virus, it basically clips off the gene for IgG1 and IgG2, and then IgG3 is the first one that it encounters, and it'll do that. So it produces IgG3. But if there's so much of this foreign protein that the immune system decides we can't do this, there's too much here, it not only has gotten rid of IgG1 and IgG2, but it also clips off the gene sequence for IgG3 and it leaves IgG4. So the basic structure of a immunoglobulin class G is it's a Y-shaped molecule. The fork of the Y binds to the enemy. Okay, these are 2 identical binding sites, and they stick onto virus. Okay, the stem of the IgG is the command to the immune effector cell. It tells it what to do with whatever's on the other end of the molecule. Okay, so you got the stem and fork. IgG 1, 2, and 3 basically tell the immune effector cell to destroy what's on the other end of the molecule. IgG4 says do nothing with it. So now IgG4 is a fine antibody, and we all make it in very small quantities. It's a fine antibody to aim at environmental irritants like pollens, peanut protein, dog and cat danders. If you're not allergic to dogs and cats, you got IgG4 aimed at dog and cat danders. If you're allergic to dogs and cats, you somehow didn't manage to aim your IgG4 at that pet dander, and you're still reacting to it. But somebody who doesn't react to it, IgG4, very useful. But IgG4, while it's excellent to mask symptoms against environmental irritants, you do not want to aim IgG4 at a replicating virus. And one of the years ago, one of the HIV vaccine candidates failed. It has 7 shots in the series, and it failed in large part because it exposed the vaccinees to so much of the target protein that the antibody response shifted to IgG4. And vaccinees that got this test experimental vaccine were actually more likely to get HIV than people in the control group. But these gene agents, they induce so much spike protein production that we switched to IgG4. And I'm going to show you a chart from a German research group led by a guy named Pascal Irgang. I'm going to show you a chart from his published paper about what happens to IgG3 and IgG4 after serial injections with the gene agent. And here we go. Let's toggle over to Irgang. Let's see. I'm on the wrong paper, but let's see. Where is it? I think it's this one. Yes. Okay. Close that. Back to this. All right. So here is, let's see if I can make this bigger. Yes. Is that better?
Yeah, I can see it.
Okay.
Clear.
So here is IgG3. This is your main antivirus antibody. So before immunization, shortly post, after like days after the first shot, okay, we got a rise. And the scale on the left, this is logarithmic. So each major division is an order of magnitude. Okay, this is not, arithmetic. So it's not what I wanted to do. There we are. So this group here, post second, is not twice post one. It's more than 10 times as much. Okay, these black lines, that's where the mean for the group is. So, but afterwards, because you've probably heard that the antibody response is not long-lived, we fall, okay, and then we immunize again. So this is, and we give people shortly, this is the third shot, the first booster, and then we fall again. Now, in this group here, the lighter gray, these are people who had breakthrough infection. So they kept a little bit more IgG3. Now, let's look over here at IgG4. IgG4 is the rarest antibody anyone makes, and it needs to be that way because of what it does, which we'll get into. So before the first shot, after the first shot, IgG4 undetectable. After the second shot, undetectable. Some weeks after the second shot, now IgG4 is beginning to climb. Shortly after the third shot, it's climbing higher. Now it does fall weeks and a few months. There's a few months after the third shot. Although these people up here in the light gray, these are the people again who had breakthrough infection. And so they got 3 shots and they still got COVID in there. Now, one of the things that's kind of important is the ratio of IgG3 to IgG4. So let's look after the second. Let's compare post second, or the follow-up post second. So IgG3 has fallen to low levels, but over here in IgG4, we're less than 10 times as high, okay. But shortly post third, this group here, they have 10 times as much IgG4 as IgG3, and by a few months post the first booster, we are probably approaching 2 orders of magnitude more IgG4 than IgG3. Now, all of these The antibodies measured in this study, these are the spike-specific proteins, or IgG. So the this is spike-specific IgG. This is not, say, the IgG that somebody has amnestically from their childhood MMR immunization, or their tetanus immunization, or anything else that they've acquired immunity to naturally. This is purely the spike-specific IgG that Eargang et al. Are looking at. But this right here explains why people who get these gene agents get more COVID, because what the IgG4 does, it binds to the virus. Yeah, it binds to it. It's spike specific, binds to the virus, but its stem tells the immune effector cell to do nothing with it. So it's like a cloak for the virus. But IgG4 has one other kind of trick that it does. It's actually capable of binding stem to stem with any other antibody. It's kind of a unique thing. And so if a virus happens to have, say, an IgG3 stuck on it, which would tell the immune effector cell, destroy this, if an IgG4 comes along and binds stem to stem, now the immune effector cell does not respond to the fork, only to the stem. And the stem of the IgG3 has been effectively masked by the IgG4 that bounds to it.
And if the concentration is an order of magnitude or two higher, then you can expect that's going to be happening in mass. I mean, the first thing that comes to mind when seeing this, and correct me if any of these assumptions are wrong, but initially off the bat, I think one of the strongest hypotheses for how SARS-CoV-2 produces symptoms was that the spike protein was cytotoxic, and that was having those effects. And so it seems kind of insane that you would then take a gene therapy to produce that spike protein that's cytotoxic and is going to potentially cause problems and be pro-inflammatory and cause tissue damage. And so, what we're seeing from this, from what it looks like, is not only like we could see why these medications would be somewhat effective in controlling symptoms once you recover from any sort of symptoms that you're going to experience post-vaccination from that release of spike protein, because you're going to have those because of the IgG4, right? Because, if you get infected again now, it's not going to keep you from getting infected, but when you do get infected and
your
spike
symptoms will be
proteins getting
milder.
pumped all over the place by the virus replicating, then that's not going to cause as many symptoms for you.
That's
But
right.
you will be more infectious for other people for sure, because you're going to have a lot more of that virus.
Mm-hmm.
And also, and I think a really big concern is that when you're, going around, and so if you don't have prior immunity, you're going to keep getting these infections. So like the prior immunity, because of antigenic fixation, right? You would typically have some of these antibodies for the nucleocapsid, different components of the virus. But if it's
Yes.
only that spike that you have any sort of immunological reaction to, like the first exposure was just to the spike,
Yep.
then forever that's going to blunt your ability to produce antibodies for those other components of the virus. And then
You're
now
exactly
you're in
right.
this situation where you're just going to keep getting infected. And every time you do, you're just going to be producing a much larger quantity of this cytotoxic spike than you would have otherwise. And it just seems like it's just a disaster long term.
You mentioned the nucleocapsid, which is one of the other components that naturally infected people respond to. Now, the nucleocapsid is it's an internal protein. It basically envelops the RNA genome within the intact virus. So if you have circulating nucleocapsid antibody, you're not going to neutralize the virus with that. But what nucleocapsid antibody does is it provides another handle for the immune system to recognize virus-infected cells and shut down viral replication. Say in the virus universe, some viruses are successful because they prevent the cellular machinery from presenting parts of the virus, pieces of the virus, on what's called our major histocompatibility complex, which is a molecule appendage that studs the surface of every cell in our body and normally just sits there. But when a foreign protein is attached and presented on the MHC class 1, we have 2 classes, but MHC class 1 complex, it tells the immune system, I've been suborned, and I'm making a virus. Destroy me. And so some viruses subvert that mechanism. They actually can prevent it from happening. When you develop a wart on your skin, and it's there for a long time, the wart virus, and this is not a dangerous virus, but the reason it's able to persist for a long time is because it prevents those skin cells from putting pieces of wart virus on the skin cell surface to signal to the immune system that the skin cell is infected. Not a perfect mechanism, and not forever. Sometimes, after, say, a wart has been present for years even, that mechanism will slip. The immune system suddenly recognizes that we got a virus-infected cell concentration there, and let's go clean it up. And the wart goes away. I had one in childhood that went away that way, but it gives another handle, another signal, a flag for the immune system to detect viral infected cells. Now, but this paper is important because I want to show those able to see video. Let's see which one are effectiveness. This one. This chart is a chart from, let me orient the listeners. This is from the Cleveland Clinic study, Shrestha et al. Published in April 2023. This is a study of 51,000 healthcare workers in the Cleveland Clinic health system. They get their healthcare through the health system, and so this was a retrospective cohort. The researchers basically obtained access to the health records of the employees because the data were anonymized. Informed consent was not required. This is essentially a public health investigation, and so nobody's HIPAA was violated. Way over here at the left, where these lines all originate from, down in the lower left of the screen, this is a zero date of 12 September 2022. So the infection histories and the vaccination histories of these 51,000 people are known, and the timeline on the horizontal axis, this is days. So 14 days, that's 2 weeks, 4 weeks, all the way out to, on the right, I think this is 28 weeks. Yeah, I think that's 28 weeks. And what we have on the left vertical axis is the proportion of the population in each of these different lines that became infected with new laboratory-proven COVID-19. Okay. this population is stratified by vaccination status. So here at the bottom, we have 0 doses. These are people who are completely unvaccinated, and they did accumulate, new infections, and then up 1 dose, 2 doses, 3 doses, and more than 3 doses. And what this is showing you is that this is a perfect epidemiologic demonstration of negative vaccine efficacy, where the vaccine actually increases the risk of infection. And we can say that by the time even you get to, actually, let's see, 2 doses at the extreme right of the time scale, 2 doses, your risk of infection is a clean doubling of from the unvaccinated person, a 100% increase in relative risk.
And when you say clean, you can see the 95% confidence intervals indicated here,
Yeah,
and it's a doubling given the 95% confidence interval.
yeah,
So it's just, I mean, this is crazy, not only because this is showing this, but also because we just established a mechanism that would explain this is
risk.
exactly what we would expect to see. And then lo and behold, we see it. So there you go. We have negative efficacy in terms of infections. And that's demonstrated not only with a plausible mechanism, but then with this data.
Yeah. So, your original thing is, or the topic that you really wanted to aim at ultimately was the risk benefit ratio, the risk benefit calculation for a young military age population. Between, let's see, so between actually starting with the infection fatality rate from Ioannidis et al. That I showed from the first, that was just the text, the age stratified infection fatality rate. We would say that the virus is not a threat to a young, healthy military population. So that's the baseline. The virus is not a threat. So since the virus is almost categorically not a threat to a young, healthy military population, you have no upside to introducing them or giving them a novel technology and experimental biological agent. There's no upside, only downside. What we're showing here is that the downside is more infections. So, we have, as you know, Grant, we have pushed the flu vaccine for years, decades. Why? Your readiness. Because, if you're homesick with the flu, that impacts readiness. But if people are going to get, more frequent infections, well, how does that not affect readiness? So what we hope to function like a vaccine, an immunization, is that actually making the infections more frequent. And so that would be a decrement, a degradation of military readiness. But this is just the beginning of the story. There was a paper that I found. I didn't have time to pull it up as you and I were getting ready for this, but they were looking at volunteers that were experimentally, I believe they were experimentally infected, and so they were followed day by day to see, when they became viremic and when they cleared their viremia. And the subjects who had were previously vaccinated with or injected with the gene agents, they took twice as long to clear their viremia as uninjected subjects. Twice as long, like 9 days compared to 4. After 9 days, they did clear virus. So the person who's received these gene agents not only spreads a higher burden, but does it for a longer period of time than the unvaccinated. There was a paper that was just published in Canada last year. I don't think I pulled that up. No. Let's just check over this one. No, that's back to the Bardosh paper. Okay. Stop sharing that. And but this paper in Canada tried to quantify based on modeling, and the model was poor. But the authors assumed, and it is right there in the paper, it's an assumption that the prevalence of immunity in the unvaccinated population would be 20%, when there was a peer-reviewed source available at the time that said in Canada in 2022 that the prevalence of pre-existing antibody was 90%, because this is now post Delta and Omicron. And Omicron was much more contagious than Delta. So people had antibodies, 90%. But plugging 20% into their model, what they were showing or tried to show was that vaccinated people actually got most of their infections from the unvaccinated people that they encountered. But some really, I think, smart critics said, wait a minute, 20%, that's unrealistic. We have data. Why didn't they use the available data? So rather than plug in 95%, they gave the assumers of 20% the benefit of the doubt, and they only plugged in 85%. And
That's
then
terrible.
the model actually flipped, and what their model showed was that the vaccinated get most of their infections from other vaccinated, and that the unvaccinated people around them actually serve as a buffer because they don't spread the virus.
Yeah, that herd immunity, right, that we were
Yeah,
told doesn't exist, and
that we were told doesn't exist.
yeah.
Yeah, so it was a pretty stunning takedown of a very poorly written paper, and we haven't even gotten into turbo cancers, autoimmune, myocarditis. Oh, let's talk about myocarditis, because that happens to a predominantly young population.
Yeah, because at this point, we're dealing with a vaccine mandate on a population with negligible risk of severe disease that we can expect will increase the risk of infection and lost work by a factor of 2 at least.
So you're
Now
talking
let's start
factor
talking
2 for
adverse events.
myocarditis.
Yeah, let's start talking adverse events aside from just being more likely to be infected.
Sure. So previous estimates of myocarditis in a vaccinated population, I think I found one Asian paper that was reporting or measuring a myocarditis rate, incidence rate in the tens per 100,000 vaccinees. I cannot remember the technique that those researchers were doing. They may have been using troponin C, which is a blood marker for cardiac injury, using EKG. Before and after EKG, there was a Thai study that found measurable EKG changes in 17 or 18% of 300 teenage boys they got pre-injection EKGs, gave them the injection, and got post-injection EKG, and they found evidence of heart inflammation in the EKG change. And these EKG abnormalities, which would be a proxy for heart inflammation, pretty much all resolved within about 14 days. And so the cheerleaders for the gene agents said, no problem. But of course, when you kill off a cardiomyocyte, you don't get another cardiomyocyte. You get a fibrocyte. That's a scar. And this is going to have downstream implications for electrical conductance within the heart. When you have scar cells, fibrocytes, scattershot throughout the heart, that essentially makes a non-conducting sieve that the electrical impulse that's triggering the coordinated contraction of the heart, it's got to travel through this sieve in order to generate the heart contraction. Notably, our own Federal Aviation Administration has, I think in 2022, it may have been 2022 or 2023, increased the acceptable PR interval, which is the interval of time between the initiation of the atrial contraction and the initiation of the ventricular contraction. The normal interval in a healthy person varies from 0.12 seconds to 0.20 seconds. The Federal Aviation Administration will now accept up to 0.3 seconds in a pilot. Prior to this change, they would have accepted no more than 0.20 seconds, because the medical definition of first-degree heart block is a PR interval of more than 0.2 seconds. But they will now accept a 50% increase in the time it takes for that electrical impulse to travel through the atria and then initiate ventricular contraction at the sinoatrial node, not the sinoatrial node, the atrioventricular node.
Maybe, yeah. So, to me, I think one of the biggest takeaways here is that your interval there going from 0.2 to 0.3, that's probably not going to be symptomatic.
No.
You're probably not going to notice, you said it was grade 1 heart block when it exceeds 0.2. You're
Grade
probably
1
not going to notice grade 1 heart block. Like, that's not going to be symptomatic. You might not even feel it when you exert yourself. So when we have these incidence studies trying to look at myocarditis, we have the evidence from the Thai study that I think is a really good study to demonstrate that some of these cells are dying.
Mm-hmm.
And really, it's just a matter of luck. If your luck is really bad, cells around your AV node are going to die, because then that's going to have the most dramatic impact on that interval, but also can be the kind of thing that results in, ventricular fibrillation in the middle of the night, where you just don't wake up.
And the public may or may not be aware. I don't know what your listeners pay attention to in the news, but the incidence of pilots having in-flight medical emergencies has gone through the stratosphere. In some cases, the pilots have died in the cockpit in flight, and the co-pilot took over, landed the plane, and sometimes they're still alive when they have these events, and what the airlines industry does in order to keep people from panicking, they don't want the public to see a pilot carried out of the cockpit on a stretcher, so they completely deplane the they deplane the aircraft, and then they let the EMS come in and get the pilot or other affected flight crew. And it's just shocking. You've got somebody that could be having a heart attack. No, no, no. We're going to get everybody off the plane first, and then the EMS can come on. There was one instance where a pilot had a seizure in flight, and his feet locked under so he went into what's called, I'm sure you'll understand what this means, an extension posture, where all his body extensors, he basically caused him to arch backward, and his legs straightened out, and his feet locked underneath the pedals. And fortunately, his co-pilot disabled the pilot's controls and assumed control of the aircraft. And then they, with the I think the flight engineer, the third guy in the cockpit, they were able to get the pilot out of the seat. But what if the pilot, instead of just having his feet lock underneath the pedals, if he had jammed his feet down onto the pedals, and he had basically put some, flight surface control surface input that maybe they didn't have time to correct, maybe at low altitude during final approach, he puts the plane into a roll. There'd be no recovery from that. There'd be no time. It was only by the grace of God that, this happened, at altitude, and he did not, do anything catastrophic to the aircraft's controls when he had his seizure. But these are happening with regularity. I have two friends who are pilots, both former Navy, retired Navy. One flies for United, the other flies for American Delta, and I do know a guy who flies for American. And they say that these incidents are becoming, frequent, compared to historical norms.
Yeah, because historical, and so I think this is a good time to kind of get into incidents and prevalence and that kind of thing, because it's really easy to look at these events and say, hey, this kind of thing has always happened before. Sometimes people in their 20s die from heart attacks. It happens. Sometimes they get strokes. Sometimes they get pulmonary edema. And that's true. But really, to know exactly what the damage is, and is to have access to the data and to do an analysis. And on that note, in the military, we have DMSS, which has all that information. It has everyone's vaccination status. It has every single medical encounter that we've ever had. And so, there is a way to try and get a determination as to what the damage is. And just looking at the Defense Medical Epidemiological Database, which takes DMSS and anonymizes it to look at population trends, there's been increases in neurologic conditions, and that's probably like the most notable one, is the largest. It's not even heart stuff, it's neurologic conditions. And knowing what we know that you said about lipid nanoparticles being able to cross the blood-brain barrier, is that not concerning? I'm very concerned about this. I've seen soldiers all of a sudden develop strange neurologic conditions and didn't even think at the time, but then walking away, people just like essentially in a wheelchair on staff duty, and then being like, after, like, wow, that's crazy. And then afterwards saying, oh yeah, maybe it was the, gene therapies that are responsible for that. And have also seen heart issues in the population as well. And I'm a physical therapist. I'm not primary care. I'm not seeing people primarily for that. And yet I'm still exposed to it. And if I'm on an installation that only has 15,000 soldiers and I'm seeing one or two cases here and there of these various conditions, like that's high. That's very high,
Sure, because you're not seeing everything.
relative to,
You're
yeah,
seeing a
relative to the
subset.
historical trend. And then people look at this on that aren't as skeptical as we are, that say, hey, they said it was safe and effective, so it's probably safe and effective. And it's like, well, how many people, like billions of people got the shot, or I don't know anybody that had an adverse event. And um, or I had the shot and I didn't have any issues. And it's like, I don't think that it's more than my 95% confidence interval is that the rate of serious adverse events is probably somewhere between 1 in 100 and 1 in 3,000. I think it's somewhere in there, for serious adverse events. And are you really going to notice that? Especially if given the politicization of this issue, where people are afraid to indicate that they think they had a vaccine injury because they get dismissed, and people think that they're being political by doing so. And the only reason I know that is because since I've been outspoken about it, people have confided in me, oh no, I think I got injured by the shot. And they tell me that they haven't told anybody else.
Much more common
Or
than most people know. So the data from Western Australia are very interesting. First, they have a statutorily mandated reporting system for vaccine adverse events. Their surveillance system is called WAVES, Western Australia Vaccine Surveillance System. Western Australia was something like North Korea during during 2020 and 2021. Kind of the hermit kingdom. They locked down the borders. They didn't let people in and out. Whenever anybody in the state tested positive for COVID, they had snap lockdowns of neighborhoods to stop transmission. It was very draconian. It was so severe, they had only 1,500 laboratory proven cases of COVID-19, but they had essentially a 100% 100% vaccination rate, because it was mandatory. And in waves, they record 3 serious adverse events per 1,000 administered doses. But they have an underreporting factor of 10. In VAERS, we have an underreporting factor that ranges between like 40 and 100. But even statutorily mandated, they still have an underreporting factor of 10, which means that serious adverse events, and they took mostly Pfizer, serious adverse events are approximately 3 per 100 doses administered. That is beyond stratospheric. It's positively astronomical for anything that pretends to perform like an immunization, a vaccine.
Yeah, and yet it's still, I should know, it's still low enough that probably if you got vaccinated for COVID, you didn't have a serious adverse event. Like 97% every time you go. So like if you only had your initial series and you got a 3% chance each time, then you got a less than 10% chance that you're going to have a serious adverse event.
Mm-hmm.
And so, these folks that dismiss these concerns and say, well, there's been billions of doses given and like the world isn't coming to an end. It's like, no, it's not coming to an end. And by all means, people that share our concerns sometimes go overboard. Like I remember Dr. Ben Marble I had a conversation with, and he's like, everybody's going to die. Everyone's going to die. I'm like, no, that's not realistic. And so people peg onto those folks, people like Steve Kirsch, and they say, then they use that and pivot off of it like this straw man. And so we're not trying to say that everybody that got this product is doomed. Um, all we're trying to say is the risk benefit might not have been there. And if it's not there, then I mean, by gosh, we got to figure out how to make sure that this never happens again.
Right. So we got away from myocarditis because in your experience, the neurologic conditions are more prevalent. But there's been a paper that's come out recently using very sophisticated, I think this would be nuclear medicine studies, um, late gadolinium enhancement, LGE by its abbreviation. And these authors found that late gadolinium enhancement is an indicator of cardiac muscle injury. And when they did this on a large population, they found an estimated uh, population rate of myocarditis detectable by LGE at 2,860 per 100,000. That's almost 2.9%, which kind of goes with, and I can't remember how many days after the injection did they do that? My memory fails. I've only read it once, and not the entire paper, and that was when the DMA came up and basically consumed all our lifespans, and disposable time. So I've got to get back to that paper, but the author's concern was that myocarditis of an autoimmune or of a viral origin can have a mortality as high as 40% at 7 years. So we're only a little bit into this. We don't know what is going to happen down the road. That's a concern. We don't know. I mean, it's too early to say the sky is falling, but 2 or 3 years farther down the road, and we'll have an idea if we're going to start seeing an increase in mortality from cardiac injury. That's
You
like
say that, but there, ethical skeptic and some other folks do a good job of trying to look at actuary tables and look at all cause mortality. And the CDC, I think, is complicit in trying to essentially make the case that there's not an increase in all cause mortality that is ongoing. Whereas
yeah,
I've seen other analysis that I think is more persuasive that shows that it is, especially for younger folks. But then you talk about an increase in all cause mortality for younger folks, say under 30 years old, and that's not a bloodbath that you're going to notice, because the all cause mortality in that age range is very, very low. And so you have an increase of 20, 30, 40%. That's not necessarily going to be noticeable.
right,
Uh, and especially if you don't account for things like pull forward effect and all sorts of subtle uh, kind of statistical games that you can play if you have an agenda that you're trying to execute.
right. I'm looking for um, the all-cause mortality chart that I had told you about previously, and this is UK data. Oh dear, here we are. No, no, maybe. That's Excel. No, that's not what I'm looking for. Um, I'm not finding it. There was there was some very interesting uh, all-cause mortality from the UK. The British government did an interesting, they're playing a little bit of games. So they're a little, in one way, they're more honest than ours, in that they posted their mortality data, but they were simultaneously a little bit clever in that they separated their their mortality from vaccination status. They put them in different tables, in different appendices, and it took some data sleuths a little while to be able to put it all together and reconstruct the not showing it, not coming up on my mortality file. I'm not sure where I put it. Oh, wait a minute, here we are. Maybe this one. This one could be it. No, nuts. Okay. All right. That's I don't know where I put it, but it was a very interesting graphic that showed at every level of vaccination, the the vaccinated constitute a higher portion of all-cause mortality than their portion in the general population. And the difference between their portion in the general population and their portion of all-cause mortality goes up with increasing vaccination. It was just a beautifully done graphic, not done by the UK government.
Yeah,
But
by somebody taking the data and then displaying it. And, I've seen also that, early kind of arguments that showed that the vaccine was having a positive effect on mortality reduction. Really, it was like if you looked at the data, it was saying that the vaccination prevented death from like violent death, gunshot wounds, accidents. And it's like, that's probably not the case. So probably whatever you did with your statistical analysis um, is not reflective of reality.
I think it's worth mentioning again, now you've said that people who got the gene agents, because of the IgG4 class shift, their immune responses, their immune systems do not respond strongly to the SARS-CoV-2 variant du jour, which means that they have very few symptoms. While it takes them a long time to clear the virus, and the virus is destroying cells in whatever tissue it's able to invade. This is why you see all-cause mortality, because the virus goes into many different tissue types, but you see all-cause mortality in the vaccinated population higher than the unvaccinated population. I've actually had a physician, somebody I met on the internet, we had an argument, telling me that he was from the state of Utah in the US. And he showed me Utah state data that claimed that all-cause mortality was higher in the unvaccinated. Now I could see, cause-specific mortality being higher in the unvaccinated. So if to say SARS-CoV-2 mortality was higher in the unvaccinated than the vaccinated, but what would be the mechanism by which a purported vaccine will protect someone against stroke, heart attack, thrombotic disorders, coagulopathies, cancer? How does that work? I don't know if you remember
The
that.
first thing that comes to mind is healthy user bias. If
Yeah,
it's actually the case that it is, there is a relationship there.
possible. That would be one, but I'm reminded of the character. I don't know if you saw George Clooney's movie Brother, Where Art Thou? There was a very plain spoken character in there, and he would have said, that don't make no sense.
Yeah, it doesn't, and the extent to which people who are paid for their clinical reasoning, right? Especially in public health, the extent to which they just threw out their responsibility to do risk benefit analysis, tried to purport a mechanism by which the things that they're recommending are going to be effective, that's plausible and persuasive. And this goes all the way back to 2 weeks to flatten the curve. Um, none of this stuff, the social distancing, the 6 feet thing that was totally arbitrary and made up. Usage of non-pharmacological interventions like masks. You know, I just
No
it was
basis in reality.
shocking. Yeah, it was shocking to see no one willing to stand up and say the things that, like, I know they knew. I know they knew these things. It was like a gigantic Ash conformity experiment almost. And so,
Yeah.
it's really good to talk to you and kind of, you know, get somebody who's like actually analyzing it. I just wish there were more folks in the military at the time this was all going down. And I know we had some, Teresa Long and Sam Siglov and Pete Chambers who all signed the DMA with us. But it was fewer than I would have thought given the circumstances.
Yeah, moral courage seems to be in a relatively short supply these days. Um, for your written documents that you talked about making about our conversation, I will find that UK graphic and send it to you. I think it would be great to include it because it's a beautiful demonstration. It's as good as the Cleveland Clinic. Um, showing a different thing, but it's a marvelous epidemiologic demonstration of what we've been talking about.
Yeah, and I'll be able to put together, you know, excerpts from what you had pulled up. It's going to be pretty easy because there's, graph, and I'll be able to kind of talk through the narrative and like a little write up. But since we've been going for a while, I think it's a good time to wrap up
Sure.
and just talk. So we talked about overall efficacy. I wasn't really there. Safety, how it wasn't really there. But what we haven't talked about is the whole idea of the DMA not even having anything to do with safety and efficacy. The DMA is just about legality,
Right.
and so a lot of people, when confronted with these concerns, they would kind of say, "Hey, nobody cares." Even though it's illegal, it's like, well, who cares? Like, it doesn't matter. Like, you've gotten vaccines before, it doesn't matter. But the reason that it matters is because, the it being legal is kind of that check to make sure that everyone did their due diligence, right? And when you have this product that's under emergency use authorization and it's being forced, so even if it's FDA approved, we have a right to a religious accommodation, right? You also have a right to medical accommodation that was totally foreclosed via that same licensure mechanism that we already talked about. So pressure was put on providers at echelon, like, you will not provide medical exemptions for this treatment, or else you're going to have to answer to me. And it's like the
Right.
next person up at echelon, all the way up to the Surgeon General for each of the respective services. So
Mhm.
that was foreclosed. The religious accommodation, with that, there's constitutional authority to mandate vaccines, going back to Jacobson versus Massachusetts and mandating the smallpox vaccine, but it has to meet strict scrutiny. You have to prove that providing an accommodation to somebody poses a grave risk of serious harm.
Yes.
And they just can't, they couldn't do that with this. And that's why not only was it illegal because of that, but it's even worse. They didn't even have an FDA approved vaccine to the point where that should have even been required. Informed consent was required. And, using coercion to get somebody to accept an experimental product is illegal and it's unconstitutional. And so if all these checks fit, like even if it did end up being safe and effective and it provided positive risk reduction, that would have been speculative at the time. Like they couldn't have known that ahead of time given what the information that was available. And yeah, I think a lot of people were kind of crossing their fingers and didn't really know and hoped, hey, maybe this will be good, even though it kind of doesn't, like we don't really know, but let's see, like maybe it'll be good. It's like you can't force people to take an experimental product on hope.
No,
And the reason why is liability. Who's accountable? If somebody gets injured, who can we hold responsible? And if
constitutional
nobody,
rights.
yeah,
Constitutional rights become even more important in an emergency than they are in normal times, because that's precisely when the government is tempted to trample them.
exactly, exactly. And there's because there's not enough time to do this analysis, or that's the narrative, right? Is we're in a hurry, we're in a rush, we don't have time to consider these things. So it's been really good to go through this detail. I learned some stuff. Like I feel like I'm pretty well researched in this topic, but I learned some interesting stuff, especially with respect to IgG4. That was fascinating. And that proposed mechanism in for why people would be more likely to get infected after vaccination, which is data that we've seen from other countries. In our own country, it's kind of been suppressed a little bit.
Mhm.
But honored to sign the Declaration of Military Accountability with you, and hoping that this issue is something that we can focus on and get accountability for, because I really do feel that something this egregious, where it just turned out to be such a disaster in terms of public health, if there can't be accountability here, when not only was it just a speculative decision that resulted in overall harm, but it was an illegally executed speculative decision. So somebody somewhere thought, hey, let's go ahead and do this, regardless of the fact that it's illegal. Even
Yep.
if it ended up working out, it would have been wrong to trample on constitutional rights to do so. But it's just that much more egregious that it was harmful. And frankly, it should be educational for everybody that this is why we have constitutional rights. It's not just a moral uh calculus, to me anyway. Like for me, it is absolutely a moral calculus, but I think there's a practical dimension where liberty and autonomy and individuals being able to make those decisions for themselves is what results in the best decisions being made over time. Allowing people to be accountable for their own health decisions and not placing that power and authority into the hands of people that it is very difficult to hold accountable. But nevertheless, we can work on trying to hold those individuals accountable that put their names on these orders.
And it's not to say that sometimes, individuals making their own decisions, for themselves may make decisions that are suboptimal or even self-destructive. That happens. But
Yeah.
that's what freedom is all about. Uh,
Yes.
when
Absolutely.
people who take the position that other people should be free to make their own decisions as long as they approve, they really are not in favor of freedom.
Yeah. And yeah, I couldn't have said it better myself. The hand wringing and pearl clutching over the fact that people make wrong decisions. Well, guess what? What did we see here? We saw the people in charge with power make the wrong decision for the population in question.
The
And
mistake we made was giving them that power. That was
yeah,
the
and
mistake.
so yes, individuals will also make wrong decisions, but then the damage is going to be
It's small,
largely limited to
limited
that
to them.
individual. Yeah,
Yeah.
and they have skin in the game, right?
Yes.
Because they're accountable to themselves. And
Right.
this lack of skin in the game from folks in public health, from commanders at echelon, who, they can make certain risk decisions that, um, they have to make risk decisions. That's what they do for a living. But uh, some of those risk decisions, they don't have the constitutional authority to make. And so, in this context, I think that that's the case. I think that we have clear evidence of that. And so I think it's a good a good place to push to try and get accountability, because it will have, if accountability can be achieved in this context, I think it will have positive second and third order effects in other areas, in other ways. This
I'm sure.
principle of negative freedom
Overstepping
applied. Yeah,
bureaucrats, overstepping their thimbleful of lawful authority. Hmm. Huge.
yeah,
Second and
absolutely.
third order.
So with
Yeah.
that, we'll wrap up. But
Okay.
thank you, Chris, so much for spending the time to go through this. And
Brad, it's been a
yeah,
pleasure.
I'll write it up, and we'll have a little article. The video will be attached to it, and then take those screenshots of some of the things that you went over in order to try and communicate this stuff.
We'll do. And I'll send you, I'll locate that UK graphic and send it to you. It was very
Sounds
good.
good.
All
Sounds good.
right. All right, Grant, out here.